I'm an sports and an arthroplasty surgeon. I do both. And here I work in the top private hospital in my country. We see a lot of patients with cartilage issues because we treat some important sports team and part of the Olympic Committee of Chile. And as we are a Latin American country, we don't have all the possibilities, for example, developed countries have. So we try to do the best with the options we have. So it's a bit different from a, for example, for a United States experience or a European experience, but I think it's still worth it. And finally, we try to be innovative. We try to be creative because of that lack of different options.
Dr. Francis, I totally disagree with you. I have been in Latin America and Chile, and I'm sure your facilities are very good. I've been in your hospital, and I'm really impressed with the kind of work you do over there. I have a very difficult question for you next. Do you remember this picture?
Yeah, that was in a match of Universidad de Chile, the second most like important team in our country. I hate it.
Yeah.
It's not my team. Like I root for the rival. So it was
Yeah.
the first time I was in their stadium. I don't go there. Only for you.
Okay. So yeah, those were nice moments. I'm happy to have traveled to Latin America as part of the APCAS SLAD exchange program, and had very good experience traveling around in multiple places and being hosted. And I will definitely say Latin America is a place that is far underestimated. There is a lot of good work, a lot of good people working over there. So without further ado,
Francisco, I just have one
yeah,
quick
Dr.
question.
Sam, Dr.
Francisco,
Samit.
I just have one quick question. I noticed that you work both in the clinic as well as the hospital. So how do you kind of divide your time between the two and yet be able to support your team and have a good time? In general, how about your work-life balance and how do you manage it?
Yes. Fortunately, here in our country, we can take part-time jobs in the public system. So finally, you can have you're not forced to work full-time in the public system if you don't want. So you can do a lot of like finally uh, helping people with less resources and still have time to work in the private sector. That I think finally is where the money is produced for us, because the public system is a bit underfunded, and with that you can still have time. That's the reason, because finally the reason is because you can have part-time jobs. Because I know there are some countries where if you want to be in a public hospital, you have to take the full-time job. Here it's not like that. Here you can work. For example, I work 11 hours a week in the public hospital, and they allow me to do that because they need people to go there, and they are happy to have people that want to go there to help and to improve the quality of life of the poor and people in need.
Superb, superb. I think we will go ahead with the academic part of the webinar. I would like to request Dr. Francisco to deliver his lecture on augmented microfracture, clinical applications, and long-term results. Over to Dr.
Okay,
Figure.
perfect. Just give me a second. Give me 1 second, okay?
It's perfect. It's clear.
Yeah, cool. Okay, so, well, again, thank you very much for having me here to the Indian Cartilage Society, and good morning here in Chile. So I'm going to present the augmented microfracture, the clinical applications and long-term results. Second. So the classic indications for a microfracture, we know that there are small defects, and here you can see that the classic microfracture has some problems, like the complex rehab procedure, and the and the and the long delay before return to sports. And finally, because of that, we changed and we started to use osteochondral autografts for small lesions because they have a primary bone healing. The return to sports is much quicker and is more consistent over time. And you can see here that looking at the literature we have produced in our team, we are big fans of the osteochondral autograft. That's why for us this phrase is kind of true, that we already abandoned microfracture, at least as the isolated form, like 10 years ago. So that is true for us. And when are we using microfractures right now? We are using them in expanded indications, in large defects, where there are other options that they have much more evidence, like MACI or like the osteochondral allografts. But we're using microfractures for them. And why? Because MACI is not available in Chile, and the osteochondral allografts, we can have them, but they are not local, so they are too expensive. So we use them only in special cases, special occasions, because we have to find a patient that is available to pay for them. So coming back to microfractures, we can recognize 3 generations. The first, the traditional, that we already abandoned it, and then the second and the third. The second are the microfractures plus an acellular additive, and the third generation is a microfracture plus acellular additives. That's the type of microfractures we are using now, as I said before, in an expanded indication. And we have published our experience, for example, using chitosan, that is kind of a cellular additive. And we have seen in patellofemoral lesions that we have good results, like they are decent. They are not excellent, but that is consistent with the literature in patellofemoral injuries that are different than femoral condyle lesions. And if we compare our experience with experiences from different parts of the world, and this one from a reliable group of the Rizzoli Institute in Italy, we can see that the experience is similar. The results are good, not excellent, but they are consistent in time. So we have been happy using this kind of acellular additive. But now, in the last years, we started using a third generation microfractures, and you can see in this systematic review that if you take all of them together, like all the types of third generation microfractures, and you group them, they conclude that the improvement is marginal and in clinical and radiological outcomes. But I think it's kind of a misleading information because you can group all the types of third generation microfractures because they are different, and the types of enhancers are different. As you can see here, the three most used are platelet-rich plasma, bone marrow aspirate concentrate, and mesenchymal stem cells. Between others, there's a lot more, but they are not the same, and they have to be studied separately because they have different results. Also, an important thing is to know that in the United States, that is the most important publisher of scientific literature, BMAC and stem cells could be the same for their publications because in the United States, one of the few forms of delivering stem cells is the BMAC because it's approved by the FDA. However, if you look at the BMAC, it contains only few mesenchymal stem cells. So it's difficult to call BMAC stem cells, probably something between stem cells and PRP. So the literature of the United States can be a bit misleading in that. And let's start with PRP. PRP, for example, this meta-analysis that shows all the studies that use PRP as an augmentation for microfractures shows that there is an improvement in clinical scores, but it does not achieve a minimal clinical difference. And finally, they support not using PRP because it doesn't make a difference. BMAC, contrarily, it's known to have better results when compared to isolated scaffolds, better results when using an scaffold with hyaluronic acid versus an isolated microfracture, and even better results than MACI. So it could be an interesting option. And also, this review too shows that they have really promising results, but always when using scaffolds, because you have to finally cut all that kind of liquid of the microfractures and the BMAC together to have the desired effect. Now, for me, the only problem of BMAC is that we usually started taking it from the pelvis, and for us that are knee sports surgeon, the pelvis could be a dangerous place, and this headlining of a local newspaper is in Spanish, but it says that a surgeon was sued because of a death of a patient obtaining BMAC in our country some years ago. So that's why we developed a different way of obtaining BMAC with an arthroscopic procedure that it's done in the intercondylar knot. We made it for a study on ACL reconstruction that is not the topic here. But the arthroscopic procedure was safe without any morbidity and without any postoperative complications, and also it allowed us to get a proper quantity of BMAC to be used in whatever we need. What about the stem cells? Stem cells, the main problem, as I said before, is that in the United States, the categorizing could be wrong in some studies because some people call stem cells what BMAC is. So if you look at the different systematic reviews, they are mostly consisting of BMAC studies, and all the studies of stem cells are just small case series or reports, and you can't get conclusions from them. The only level 1 article on stem cells is this one, and it doesn't show any difference between using microfractures and PRP and compared to microfractures, PRP, and adipose stem cells. And the only difference is in the histological characteristics of the repair tissue, but they only studied 2 patients per group. And finally, that can't allow you to make any real conclusions. So finally, I would say that stem cells, they have limited evidence, and they shouldn't be recommended, at least for now, to use it in chondral injuries. There are some new therapies that finally there are different drugs that they could enhance microfracture, but they are still in laboratory studies, and they are in an early study phase. For example, drugs for blood pressure, for cancer treatment, or even supplements have shown to produce better collagen, better cartilage, to produce chondrocytes, or to eliminate senescent cells. But this is still some early phases of our investigation, and it's not a recommendation. I participated last year in a consensus that produced a whole number in the Journal of Cartilage and Joint Preservation, and in the part of bone marrow stimulation. You can see here that when it was asked if the surgeons consider orthobiologics in conjunction with microfractures, there were no consensus, but almost 2/3 of the surgeons, they agreed that microfractures, they shouldn't go alone and as an isolated procedure. And almost the same number of surgeons, they agreed that they should go with an scaffold. What does that mean? That the microfractures are not like widely used now as a like enhanced procedure, like enhanced microfractures, because they have other options like allografts or like MACI, but it could be a good option in countries where you don't have these options available easily, at least. So as a summary, I would say that augmented microfractures are not widely used, and we are using them in an expanded indication because we don't have the other options that have much more evidence. As I said, osteochondral allografts and autologous chondrocytes. That PRP is not recommended as an enhancer. That the best combination is microfractures plus BMAC plus an scaffold, and stem cells still have limited evidence and shouldn't be recommended for its use. I also want to invite you for ISACOS this year. It's going to be in Munich, and maybe it could be a great moment to see each other and to share our thoughts and our experiences from different countries and different worlds. So thank you again for the invitation, and I hope to see you somewhere else in the world.
Thank you very much, Dr. Francisco. I think, as you pointed out, the augmented microfracture is a very vague term. It definitely says something more than microfracture, but as you pointed out very clearly, there is a large spectrum there, which is going to make it look kind of not so good outcomes, but we are yet to wait and watch. Dr. Navledi?
Yeah, it's a very good presentation. You are very clear, and we liked it. I'd like to add 2 points on it. Interesting concept when you told about your BMAC taking from the iliac crest. and so you switched over to the intercondylar area. I would like you to quote on the paper that the bone marrow arrived from the iliac crest versus the tibial crest versus the vertebra. They found the mesenchymal, the concentration threshold or more of number of mesenchymal is more in the iliac crest compared to the other two areas. So I think maybe keeping in that mind, maybe that may be one of the positive findings. You can still think of arthroscopy knee surgeons taking the iliac crest bone marrow. That was, I was just going to talk about that one thing. And second thing is, what is your role on your about nanofracture? Your experience, Frank?
Yeah, about the iliac crest and the difference between the iliac and crest and the intercondylar knot. Yeah, I'm aware of the difference in concentration. We think, but we don't have evidence of that. But we think that it's not relevant for chondral injuries. But as we are knee sports surgeons, we prefer to take it from the intercondylar knot because as I said in the presentation,
Yeah.
there have been mistakes taking it from the iliac crest, and they could be really bad. So
Okay, I thought as an orthopedic surgeon, it's very easy for us to take in the iliac crest than the thing. And do you
yeah,
come across any, because you're already doing here in the knee, do you come across any bone edema because you're going to take the BMAC from the intercondylar region, whether that will hamper the healing of the whatever the procedure what we do?
no, we did the study and we did a study for ACL injuries really, and finally our study is being published. It shows that BMAC doesn't work for ACL at all. Okay, it doesn't do anything for ACL.
Yeah, I think.
But it also shows that the procedure was safe. We did MRI follow up for all the patients, and there's no any difference between harvesting MRI there or at the iliac crest. There's no difference in bone edema, pain. No, it's a completely safe procedure. And about nanofractures, we started using them, but the reality is that we haven't seen any differences between nanofractures and microfractures, aside from finally the destruction of the architecture of the subchondral plate. So I think where the nanofractures should be used, I think I think they are more important in small lesions that in our indication. That is finally our indications. I know it's not the classic one. It's expanded because I think microfractures, they should be used in small lesions. But for small lesions, we prefer osteochondral autograft, and I think for for these large lesions, I think classic microfracture is just fine, but when used with an augmentation.
Yeah, that's very nice to hear from you. And one more last question. Now, since the microfracture is augmented with a lot of scaffolds with BMAC, have you come across any excess growth of the cartilage which is causing impingement, especially in the patellofemoral lesions, especially when we use microfracture augmented with scaffolds like Hyalofast or Shitashine as that? Have you come across maybe post-op 6 months, 1 year later, like excessive cartilage formation, which again cause impingement of the patellofemoral area?
Yes, and usually I think it's something that it has to do with the indication, because I think when we expand our indication too much and we treat a big injury, but in an old patient that already has a bit of arthritis, I think there is kind of an inflammatory environment that produces this kind of abnormal grow up of spores there in the zone of the lesion. So, but in young people, usually that doesn't happen. So I think we should like get better indications, because probably at some stage we were treating people that they already had, like, for example, mirror injuries, or they already had some small or mild arthritis. I think those people, they are not good candidates.
Thank you for that. Yes, Sashi, you have any questions?
Oh, Dr.
I
Sumit?
have one.
Sumit?
I have a couple of questions to Francisco. First of all, Francisco, wonderful presentation. I mean, it was really very clear, and you were uh, very good with elaborate with explaining. So I have just a couple of questions. So the initial concept of augmenting the microfracture was that the healing was coming from our subchondral drillings, and what we were trying to do with the augmented bit was trying to sort of concentrate it within the lesion, and the cells were coming from that microfracture part, and what we were trying to provide is maybe a scaffold or some sort of a structure to hold and concentrate it there. So as you've said, there are a couple of generations, one with the cellular one and one with the acellular one. So vis-a-vis, has there been any study or you have come across in your experience the difference between having just an acellular, just a scaffold with the microfracture, vis-a-vis putting in a scaffold and some cells as well? So is there a direct comparison between the two in terms? Because essentially putting in BMAC and a scaffold and the microfracture as well, it is kind of like, throwing the whole kitchen sink at it, uh, sort of it.
Yeah, no, the reality is I haven't found studies comparing acellular with cellular microfractures. I think it's probably, I think finally which one to use. I think it has more to do with where you are, in which country, because for example, United States, they have a lot of studies with MIVAC, and but for them the main problem is the FDA, because most of the acellular augmentations, they are not FDA approved, and
Okay.
and stem cells on the other side, they are not FDA approved too. So I think it has to do with that. I think that's the reason they use a lot of BMAC, and here in our country we can use whatever we want. Finally, our only problem is the money, finally. And that's why in our country, second generation it's much more used, because it's cheaper than third generation, and at least for us, it has shown decent results. We can see that are excellent, but they are decent for these expanded indications.
Yeah, that was excellent explanation. So Sumit, do you have any other question?
More about scaffolds, and do
Sumit, we are losing you.
fold among this. Hi,
I think
am I
Sumit,
now
we are not
audible?
able to hear you.
Yeah, I think it's getting better now. Sumit?
Better now. Yeah.
So can you hear me now?
Yes.
Yeah, all right. So my question was to Francisco. Uh, the scaffolds that are around, is there a better scaffold? Are there, I mean, is one scaffold preferred over another, or is studies or your experience with a specific type of scaffold that works better with the augmented microfracture?
Yeah, well, scaffolds, it's a full world. Well, for us at least, because I think there's no like good evidence to support a scaffold, a specific scaffold. For example, there are some studies that they support the hyaluronic acid scaffolds, like one there is in the market that is really well known, but the reality is that we specifically prefer scaffolds that can be sutured to the lesion, because there are some scaffolds that, well, I'm going to talk a bit colloquially, but there are some scaffolds that are like a napkin, that they look like that they just
Water
you
soluble.
just
Water soluble. Hydrophilic scaffold you're talking
yeah,
about?
exactly.
Okay.
Exactly. And they you just leave them there, but you never know if they're gonna stay there. Like you're not sure if they are gonna stay on place, because it's like I don't know, for me it looks really unstable, that. So I prefer scaffolds that can be sutured. I think that's my only recommendation.
That's a good one.
Thank you. Thank you, Francisco.
Dr. Manish Devedi.
Yeah.
Hi, Dr. Manish.
Hi.
Do you have any questions for?
Yeah. Just Sumit asked, I have the same questions, the preference for a scaffold and everything, because it's the market is newer and newer scaffolds are coming. Rather than giving the answers, they are creating more confusion. The scaffold part. So Sumit has already asked and Francisco has already answered. So nothing to ask.
Thank you. Thank you.
Thank you very much for a wonderful presentation and the following discussions. I think there are too many variables in play here. We think, and again, as Francisco you said, we think that augmented microfracture with stem cells is better than augmented microfracture with bone marrow concentrate, which is possibly better than augmented microfracture with acellular matrix, better than microfracture, or again, nanofracture better than microfracture. But too many variables in play here. As I said, some people use PRP, some use the bone marrow aspirate concentrate, some use mesenchymal cells, some don't use anything, just a gel, and some do microfracture, some do nanofracture. And sometimes the matrix that is being used is different. It is a solid collagen double layer sheet matrix, or sometimes it is just a PRP matrix or fibrinogen matrix. There are too many factors in play. I think in order to get any idea, to start with, I think we need a lot of animal studies comparing one specific treatment method in comparison to the another. I think that was a beautiful discussion here and a very good take-home message. Thank you so much. If there are no further questions, I would like to go ahead with the next presentation. Over next, we have Dr. Naveen Tripathi. Dr. Naveen Tripathi joins us from Nepal. He is here to make his case presentation, his experience of single-stage ACL reconstruction with arthroscopic mosaicplasty for a large osteochondral lesion of the medial femoral condyle. Before that, Dr. Naveen Tripathi, can you please tell us the kind of practice you are in and how your cartilage work started? How long? Can you tell about yourself?
Yeah. Good evening, everyone. So I'm Dr. Naveen Tripathi from Pokhara, Nepal. I did my fellowship in arthroscopy, that was 1 year fellowship under Professor Amit Joshi on 2019, and then started doing arthroscopy. And recently, few months back, I had an opportunity to do my short-term cartilage fellowship organized by Indian Cartilage Society. So it was a traveling fellowship, and it was a very wonderful experience, and I learned a lot of cartilage surgery. So I've been working in Manipal College of Medical Sciences as an assistant professor. So I do a lot of arthroscopy there in a medical college, and I work in a private hospital also, where I do a good number of arthroscopy cases. So that's my work. So today I'll be discussing on one of my case that was asked to present in this webinar. So can I share my screen, sir?
Yeah.
Yeah,
We
it's
can
there.
see your screen.
You can
Please
see.
make it slideshow.
So can we start, or?
Yeah, you can
Yeah,
start.
you can go ahead, please. Make it slideshow, and then you can go ahead. The stage is yours.
Okay. So is the full screen visible, sir?
Yes, yes.
Right.
Yes, go ahead. Go ahead, Naveen.
Please go ahead now, Naveen.
So I'll be presenting this case, and that is a single stage ACLR with arthroscopic mosaic plasty for large osteochondral defect of medial femoral condyle, one of my experience. So the patient is a 28 years young male. So he had a 2 months old left knee injury, and he presented with pain and instability of his left knee. So he's not a professional football player, but he tells himself that playing football is his hobby. So on examination, he had a 5 degrees of extension lag and a positive Lachman test and McMurray's test. So on MRI, we found that he had ACL tear and defect of the medial femoral condyle, osteochondral defect. So you can see in the sagittal section, there is an osteochondral defect, a large osteochondral defect, and in the notch area, there is deficient ACL. So there is ACL tear over there in the sagittal section. And in the coronal section also, in the medial femoral condyle, there is a large osteochondral defect seen in multiple sections of the coronal image. So when this kind of large osteochondral defects come, so what are our options for treatment? So mainly we can go for ACI or MESI, or we can go for a recent trend that is called for scaffold surgeries. But unfortunately, at our part of the region, this is not available. So we have other options like mosaic plasty and microfracture. We had been doing microfracture, but since we know that microfracture doesn't have good long-term results, as it forms a fiber cartilage and not instead of hyaline cartilage, so we planned for mosaic plasty for this patient. And coming regarding the stage versus single stage surgery, ACI and MESI is a stage surgery, but mosaic plasty and microfracture, they can be done as a single stage surgery. And about mini open and arthroscopic mosaic plasty, it is always better that you can go for a mini open mosaic plasty. But if you can manage with the maneuver of extension and flexion of the knee joint and use of multiple portals, extra portals, so that you get a perpendicular approach while harvesting, then you can go for all arthroscopic as well. So on diagnostic arthroscopy, you need to evaluate the osteochondral lesion. We look for the size of the defect, the depth of the defect, and look for any loose fragments surrounding the defects. Then we plan the number of plugs required as a mosaic plasty to fill all the defects. So this is a diagnostic video of the medial showing the defect in the medial femoral condyle. There's a large defect on the medial femoral condyle with the loose fragments surrounding the defects. So after seeing these loose fragments, you need to properly debride these lesions, and for the preparation of these lesions, we do a proper curettage of the debris and calcified layer over the base or subchondral bone, and then we make sure that the loose fragments are taken out and stable and vertical ridges are there on the side to hold the plugs. So coming from donor side for mosaic plasty, where to take the osteochondral plugs from. So mostly we take it from the non-weight bearing area. We transfer the osteochondral plug from the non-weight bearing area to the osteochondral defect that is in the weight bearing area. So we try to transfer from non-essential part to the more essential part where it is symptomatic. So we can take is the various size. So mostly we take it from the lateral cochlear ridge and medial cochlear ridge, and also from the intercondylar nodes. So as number required, we can take from these areas osteochondral plugs. So you should always be prepared with the oat set ready in your operation theater. So there are multiple companies, but I'll be using Arthrex, and the blue instrument that is for the donor area, and the white one is the recipient area. Prepare the recipient area. Blue one is to harvest the donor side, and the blue like rod like structure is the tamp, and then we have a white rod like metallic structure that is the depth gauze. So while how to harvest the osteochondral graft, so the most important part is that you have to be very much perpendicular. Your approach has to be very much perpendicular to the surface of the cartilage. That's the only important part. Do it mini open or arthroscopy. So there are laser marks on the instrument, as you can see. So that also helps you orient yourself if you are going right or not, while it should be parallel to the surface or as you go in. So you can take up to 0.8 mm to 14 mm of the depth of the grafts. So you can see that when we take harvesting a graft, we gently hammer the graft, and after orienting ourselves, and it's important to have a 360-degree orientation of the your view so that it's very much perpendicular. And after reaching desired depth of the osteochondral plug, then you have to do a 180 degree of clockwise and 180 degree of anti-clockwise maneuver to break that plug, and then do a twisting motion to remove the osteochondral plug from the donor side. Now coming to the recipient area, we have to be again very much perpendicular to the surface and take help of the laser marking as we go in. And then the amount of depth we go in is always dependent on the amount of osteoplug we have harvested. It should be 1 or 2 mm less than in the recipient side. And then again, same, we have to do a 180 degree of clockwise and anti-clockwise maneuver to break that bone plug and then remove it. So it is very much important to note that while the recipient area, you have just removed the bone plug and prepared for the transfer of the osteochondral graft, but there can be a mismatch of the donor and recipient side. So before trying to go and fit the graft, you should always take a use of your depth gauge and confirm the depth of the rod. So this is the depth gauge rod. You can confirm that if depth is okay or not. So it's a 14 mm. So it's our desired socket. So now we'll take our osteochondral graft and pass it to the desired recipient side with the help of the plastic tube passer that we have, and it's a screw home mechanism on the top of the graft harvester that push the graft out of the graft harvester instrument. You can see the graft coming out. So we do not push the graft to the full with this one, but we just lift the last portion. We take the help of a tamp. There is a tamp that we take, and then we just this blue rod we held and do a gentle hammering, and then the final seating is done with the help of the tamp. So it is important that the graft is fully seated and is flushed with the articular surface. Now then we repeat the same process, take a second plug, and then in the recipient side again, your planned area, you took a for the second plug, you go perpendicular to the surface of the chondral cartilage. Then video is not playing. Just a second. Okay, so I just missed one video, but no worries. So this is the second plug we are putting inside the recipient side that we harvested, and then it has to be very much we flushed with the artificial. The final flush seating is always done by the gentle tapping with the tamp and not with the graft push that clockwise mechanism. So we'll take help of a tamp. We introduced this blue rod that I was talking about in the oat set. We'll take that blue rod and then we'll pass it inside and then tamp it to further fully sit on the graft. So it should be fully flushed. So you have to be see that the two grafts has to be flushed, and then there is a debate on if it not perfectly flushed, can it be bit proud or can it be a bit recessed? So there are a lot of group of people who say that a 1 millimeter proud after the joint is loaded, it will get flushed nicely, but still the consensus is that it should be 1 mm recessed then 1 mm of proud, and the planning of your first, second, and third graft should be properly done so that you know where to keep your third graft and fourth graft sequentially. So now we are taking the third osteochondral plug and keeping that same process. We're repeating the same process, but we know where we are keeping. So it should be always a plan so that you don't get a mismatch of the mosaic-like pattern. So this is our third graft. So the number of grafts required, you just repeat the same process, and then these osteochondral grafts is formed in a mosaic-like pattern. That is your mosaicplasty for cartilage repair. So to reduce the donor side morbidity, now what we do is we take the recipient bone plug and transfer to the donor side socket, and then that bone plug we slightly tamp so that it sits properly and do not get as loose fragment in the bone joints. So after completing the mosaicplasty, I go for an ACL reconstruction for this patient. I used a hamstring graft and used a suspensory fixation on the femoral side with a tightrope type of device. And on the tibial side, I used a biocomposite interference screw. So I use an adjustable loop so that I do endo button flipping under direct vision so that it just keeps outside the bone. And then since it's adjustable loop, I slightly pull the thread and then the graft passes to the tunnel. So you can see that the ACL is also being reconstructed with the hamstring graft, and then on the along with the ACL graft on the medial femoral condyle, you can see that there is a mosaicplasty, very nicely done mosaicplasty, that is cartilage repair along with the ACL reconstruction. Is a single stage surgery. So these are post-op X-ray. The endo button is nicely placed, screws are nicely placed, and I usually keep the patient for non-weight bearing for 6 weeks with range of motion exercises. So the take-home message is that mosaicplasty is a single-stage, cost-effective option for the treatment of large osteochondral defect. Long-term results in young adults with relative contraindication in patients more than 60 years of age, and in mini open or arthroscopic is surgeon's perspective that only important part is that it should be perpendicular to the joint surface and plugs should be flush to the cartilage surface, but it can be, if not flushed properly, it can be 1 mm recess better than proud. Thank you.
Thank you so much, Dr. Naveen. That was a very interesting presentation, and we are happy to learn that your fellowship with the Indian Cartilage Society in India has made a huge impact in your practice back home in Nepal, and I'm sure that is going to benefit a lot of patients over there.
Yes.
One quick question. How do you decide, or why did you decide to do the cartilage reconstruction before ACL reconstruction? Do you think that will benefit you? I mean, what advice do you have with deciding what you should do first?
So in setting of axial reconstruction in a single setting with mosaic plasty, usually we do axial reconstruction first and then go for the cartilage repair. But since it's my first case and the lesion was big, my concentration was fully on that mosaic plasty, how I'm going to. So I went on to do mosaic plasty first. I was not sure if I would not be able to do a good to the patient. I planned I will do just 1 or 2 plugs and do a microfracture surrounding and then go for axial reconstruction. So these are just a particular case. Usually it has to be a axial reconstruction first and then mosaic plasty.
Yeah, I think you still made a wonderful job with this particular surgery. But in Navlidi, you were about to ask something.
Hi, Dr. Naveen. Wonderful surgery, real biological replacement. We are happy to see your surgical skills. And I know Naveen is a wonderful person, and the surgery is also wonderful. And only my thing was your ACL fit graft. When you're taking on the lateral plug, do you find it any difficulty to have your, because you're going to take a big graph about 14 on the lateral femoral condyle, and then when you're going to put a tunnel, when you're going to drill, have you come across, when you take multiple plugs, have you come across anything? Because you did the vice versa, first mosaic plasty, then ACL. Just wanted to know.
Yeah, probably if I had done the first ACL, then probably there could have been a risk of cutters or break of that thread. But I didn't find any obstruction while doing the drilling the femoral tunnel.
Okay, okay. So it went off smooth.
So my question is, what is the exact size of the plug you'd prefer? So they say that it's 8 to 10 mm, but I was not so comfortable, so I went up to usually 14 to 12 mm of my plugs.
No, it depends upon
What
the
is the
size.
exact?
You see, basically you have to get the joint congruity. So the number of plugs depends upon the size of the lesions. So sometimes a big lesion, your 2 plugs cannot fit the big lesion, but a small 3 plugs can fit the big lesions. That is your call on decision. It is not necessary. There is no difference between putting a 5 mm plug or a 6 mm or 8 mm plugs or a 10. So sometimes you will be able to accommodate the defect with a 3 smaller plugs than 2 big plugs. Then
So
you'll get a more space. If
my
you put 6 plus big plugs, you get more space, and the bone quality also matters in that, taking and then putting on the recipient side.
my query
So
was
you
depth.
have a
Depth
template
of
in that also has a size. You first, before you decide, you can put that sizer to see if whether you put 2 plugs is going to fill the area, or you're going to put 3 plugs, smaller plugs is going to fill the area, and size it. Then you can go for the harvesting. That will definitely be a good choice.
Thank you.
Yeah, Naveen, so I think your question was regarding the depth of the plug. Yeah. So again, that will depend on the depth of your lesion, right? So the depth of your lesion, once you've curated it out and created the margins, what is the depth of the lesion from the articular surface? So you want that much amount plus a certain amount of good amount of subchondral bone plug to give it anchoring. So depending on the lesion, once you've created that, curated out the lesion and prepared the bed, then you will decide on your grafts. There is no one single size fits all approach
Yes.
to that. So you'd have to sort of individualize it to your lesion once you've curated it out. That would be the plan. Right.
Thank
So
you.
I actually have a question to Dr. Navlari, Francisco, Sasi, right? So Naveen has done a wonderful job here. He has put in, I think, 5 plugs, Naveen. So
Five.
yeah, right. So given the size of the lesion, uh, what would be your first point of, or what would your first choice of treatment plan would be? Given that, let's assume that we have everything at our disposal. If that was the case and this was the lesion, what would you go? We'll start with Francisco first, then maybe Dr. Navladi, and then Dr. Sasi and Dr. Manish can let us know about that.
Yeah, the reality is if I would have like anything I want, I would have used an osteochondral allograft because we love osteochondral allografts, but when lesions are larger than 2 or 2.5 square centimeters, usually the number of grafts you have to take is too big, and the possibility of having morbidity in that knee is quite big too. So if I would have anything in the table, yeah, I would prefer an osteochondral allograft. But probably in our hands, I think the resolution was perfect for the case with the means you had. And probably we will have used some kind of enhanced microfracture because of that. Because as I told you, we don't have that good availability of osteochondral allografts.
Dr. Navarrete.
Hi. Just a small question before I answer. How was the patellofemoral and medial tibial femoral joint, Naveen? Because it is
So this patient was a young patient. They were perfectly fine, sir. Patellofemoral fine and trochlear region was perfectly fine. 28 years means.
okay. Alignment was okay.
Okay, sir. Alignment
Yeah.
was also okay.
Yeah,
No
because
issue.
there was no long length X-ray, just to get to know. But if you feel that alignment is okay for such a big defect, I would prefer an ACI, autologous chondrocyte implantation, for this case along with the ACL.
Hope we can get that ACI in future in Nepal also, sir.
Yeah, sure, definitely. No, he was given Shashi has given, something like, he says everything is available on the table. Sumita said everything you have. So when you have everything, yes, I would
Okay.
for a larger defect, because I'm little skeptical when you put more than 5 plex the morbidity on the knee. I'm little, skeptical. And then sort of little larger defect, I feel that ACI definitely, autologous chondrocyte implantation definitely works well, because in India we have this ACI freely available. So I think ACI along with the ACL would be definitely my choice. Sumit, for you.
Thank you. Sasi, anything differently?
Yeah. I was going to reflect in similar lines. Considering the large size of the lesion, overall conceptually, I would prefer to do a cell-based reconstruction rather than augmented kind of reconstruction. And I mean, I will come to the second part of it later. And in the cell-based reconstruction, I do reflect on what Dr. Navarrete said. Considering that the subchondral bone is quite good, I would prefer to do an autologous chondrocyte implantation without any bone grafting of the undersurface. Definitely, I mean, comparatively, possibly ACI is better than mesenchymosis. Again, possibly. All studies do not reflect this. Uh, Studies often say that mesenchymosis are as good as autologous chondrocyte implantation. But there are also reports that say that the intralesional osteophyte risk is higher with mesenchymal cells than autologous chondrocyte implantation. But when we have limited results, limited evidence, then we have to go by logic. So I would possibly prefer autologous chondrocyte implantation. But why not allograft? Not allograft primarily because I don't have experience using allograft from India. So possibly I'm scared of it. Possibly I'm scared of the literature evidence, the possibility of osteonecrosis of a large allograft in comparison to a small allograft. But Dr. Francisco should be able to tell us better if there is a higher risk of osteonecrosis of the grafted part of the bone. So that would be my preference as well. Dr. Francisco, do you have, I guess you have done allograft for your patients, and have you seen osteonecrosis in the graft?
Yeah, well, my experience is not big. It's not big in allografts because we don't use it a lot. But in the cases we have done it. No, we don't have any experience of osteonecrosis, and I have some relations with surgeons that they do a lot of allograft surgery. in United States and Europe, and they showed their results, and they said that because you have to finally, if you use it fresh, okay, that is finally before 1 month of the job of the patient, you don't get that kind of problems. Maybe if you will start using some kind of a fresh frozen or older allograft, maybe that could be a concern. But in the case of a fresh allograft, I think it's not a problem.
Okay, Dr. Sumit and Dr. Manish, your choices.
So my choice, if I were to start off again, if it's going somewhere beyond 4 or 5 plugs, again, I would probably go for an ACI/an allograft. The problem with the allograft is the timing of it. As Francisco has already said, it is the fresh ones are better. So you have a very limited kind of a 2 to 3 weeks window. So in that case, I would say if there is one available, I definitely love to go for it. But most often than not, I would probably, if it's going beyond a 4 kind of plugs, then I would probably be going for an ACI as my first choice.
Dr. Manish.
Yeah, same with me. If I can't get away, allograft is totally out from in my place. It's very difficult to get it. So it's a question between a mosaicoplasty and an ACI. So it all depends upon the cost of the patient, because actually the patient has to bear the cost. So mosaicoplasty vis-a-vis ACI, mosaicoplasty is a cheaper option. So if the cost is taken out of context, my first goal is always ACI. Second, mosaicoplasty in a larger, when I have to check about the graft size as well as the filling percentage as well as the donor side morbidity, everything. When I have to consider it, my first go will be ACI, then I'll go with the mosaicoplasty.
Okay, thank you very much, Dr. Manish. I think the point here is there are many treatment options for a reason, and there are many factors that decide what treatment option you can offer to your patient and could be best for your patient in that locality for their socioeconomic status and demographic factors, etc., etc. But
Uh,
I'm sure what Dr. Naveen has done is a wonderful job. Dr. Naveen?
so I have one question. So what about mince cartilage? So is there an option for mince cartilage in this case?
No, I mean, that's a big lesion. No,
No.
Yeah, definitely no, it's too big.
too big a lesion. Whatever you've done is very good, Naveen. We are just only discussion. One of you're really the post-op and other things is really excellent one. And for a young patient, you're given back his biological knee. That's very good.
I think I would beg to differ with respect to men's cartilage. I think we are not specifically averse to doing men's cartilage reconstruction because of the size of the lesion alone. Yes, possibly, if you don't have a cartilage fragment that is of sufficient size from where you can take the sufficient volume of cartilage. Possibly, yes, but again, men's cartilage, there are many ways of doing it. You can also harvest some cartilage from the periphery of the trochlea or from the notch region, so you can add more volume to the cartilage that you have in your hand. And you can always mix men's cartilage with all the other matrix material that we have been talking about. That includes the double layer collagen sheet or fibrinogen gel or whatever. But again, the evidence is not so clear because men's cartilage itself is a relatively new treatment option. But over time, the animal studies and lab studies and even clinical studies appear to show good results for men's cartilage, even in the form of active production of extracellular matrix in biopsies. So I think men's cartilage has some promise, but we are still yet to see Possibly the size, I mean, in my opinion, the size alone is not a detrimental factor to decide men's cartilage. It is also one of the treatment options. It is just another treatment option. I would be happy to hear other views.
So, Sridhar, I have one question for all the panelists. We can have a discussion. So, the Navin's case was a single stage. Suppose you are doing it in a two stage. So, the choice of your thing will change from mosaic plastic to something else. Means doing in single stage and doing in multi stage. Does the choices how you're handling a cartilage, does it affects?
Yeah, I think it's a very tricky question. So it can be this way, or do you say the sequence can completely change with this condition. We have always been taught that alignment and stability is primary. And if that is not achieved, then we should not go ahead with a cartilage reconstruction. So I would go ahead with this principle. If I'm doing this, I mean, if I'm treating this patient in two stages, I will like to do the ACL reconstruction in order to provide the stability for the joint and prevent any cartilage reconstruction from getting damaged and not have good outcomes. But I would prefer to go ahead with the second surgery as early as possible without wasting a lot of time. But when we are doing it as a single stage, possibly the same principle also works. Again, stability is required to preserve the cartilage. So do the ACL reconstruction first and then go ahead with the cartilage reconstruction. Also, after you have done your cartilage surgery, there is likely to be a lot of bleeding in the joint. So that can make your ACL reconstruction surgery a bit difficult and you may have to manipulate the joint a bit. So again, possibly damage the cartilage. Dr. Navaludi, sir?
Yeah, see, initially the two-stage procedure was required for harvesting for autologous chondrocyte implantation, but with advanced techniques, now a simple Jamshedi needle of 18 gauge or 16 gauge, what we do is we do under local CT guided. Use a Jamshedi needle, local CT guided, and then we harvest the cartilage for the ACI, and then we send it. So after 4 weeks, when they come, we do both the procedure together. Initially, since they needed a 10 millimeter plug subchondral along with the cartilage, we used to do the diagnostic scopy, find out, and then harvest it, send them as the patient to come again, do a ACL and other things. But now, with this, just take a CT guided Jamshedi needle cartilage. That much is enough for them to get the autologous chondrocytes, which is enough for us. So we use as a single stage surgery both ACA and ACL reconstruction.
That is
Because
very
that's an
interesting.
advantage of CT guided cartilage harvesting under local anesthesia as an outpatient. It had given a big advantage for us to prevent this two stage for ACI nowadays. Previously, it was two stage, but nowadays we are happy to do in a single stage because the harvesting was not necessary for a two stage.
Yeah,
So,
the first stage becomes like a local anesthetic procedure.
yes,
I think this is very interesting, and there is a lot of
yeah, we had done
uh,
5 cases under local anesthesia. We use a Jamshedi needle and a CT guided. That is more accurate, CT guided. They help us some volumetric analysis, and then with the help of radiologists, interventional radiologists, CT guided cartilage, we do the harvesting because they wanted some cartilage from the nose initially, but we couldn't get that much number of cells. So 1 or 2 cases were not sufficiently matured. So we went back to this CT guided cartilage harvesting, and then that did give us the adult live chondrocytes numbers what we require for the size of the lesions.
So, I just have a couple of questions to Francisco. These are from the live chats we've gotten from the YouTube viewers. So, Francisco, these are the questions for you. So, the questions are, the first question is that uh, does the addition of that augmented a cellular or a cellular scaffold, does this increase the duration, the durability of your outcome? And does it also affect the type of cartilage that is formed in the lesion? Part question one. And second is, you said that your indications for an augmented microfracture are where the size is larger. So let's say you went in and once you've curated out the lesion and prepared the bed, you find that there is some amount of injury to the subchondral bone as well. So in that case, would you still go ahead with your augmented microfracture, or would you change the strategy?
Okay, so in the first question, the reality is that we have never done we don't do second looks here, so we don't do biopsies. All the follow-up is by MRI, and we use a 3 Tesla MRI machine that can give us that nice view of cartilage and even some special cartilage protocols to see the structure of it. So we can't know if finally what grows, if it's different from a common an isolated microfracture. But what we know is that it's thicker. And it has a more hyaline-like structure in MRI, compared with a microfracture that is just fibrocartilage. Okay, but as we don't take histological samples, we don't know that for sure. We only know that it's thicker, and in our study, in the latest study that I show you from the Rizzoli Institute, they observed the same, that finally the results, they tend to be consistent over time. That even in the 5-year follow-up, you keep results that are similar to the initial results. So I think they work for special indications, but of course, in cartilage is different. It's difficult to compare between different treatments, but our experience has been good. Then the second question: if we find that the subchondral bone is damaged, no, we don't go with the microfractures. When that had happened, we have changed our plan, and usually we don't have the allograft available at that time. So finally, what we have to do is just close and then ask the company or the patient to buy an allograft. We don't use autograft in those cases, because as I said before, we use autograft only for small lesions, not for big ones. And so and we don't have autologous chondrocytes here in our country, so it's not an option for us.
Thank you, Francisco. Thank you for your answer. So I think the philosophy is that it does work. The functional and the MRI results are better, and of course, it is looking to be more durable. But we'll have to wait from other studies, maybe from some other part where the biopsies can be done to look whether it's actually hyaline. And as this part of the second, yes, the subchondral bone is critical whenever you're doing a microfracture, whether the lesion is small or large, it doesn't really matter. If it's a small, you'd probably go for the autologous transplantation. If it's a larger lesion, then you'd probably look for other methods, maybe a cell-based or an allograft one. Great. Thank you. Thank you, Francisco. Thank you so much.
Do we have any other questions? Dr. Mani, Dr. Navladi?
No, thank you so much.
I think this was an awesome discussion.
On behalf
Thank you so much, Dr. Francisco. Yeah, over to Dr. Navladi.
On behalf of our President Rajat Zangir and our scientific committee and myself, we invite both Dr. Naveen Tripathi and Francisco to come and attend our upcoming Indian Cartilage Society meeting in November in Delhi. We will send you the invitation. Francisco, please, you should join us to come and share your experience with us in the Indian Cartilage Society. Thank you so much, Shashi, for organizing, Sumit and Manish, to take this ICS 3 webinar in a big way. And most of them are learning a lot of things, and they're very happy. And it was excellent talk by both the speakers. Over to Shashi.
And let us all also join Dr. Francisco in ISA course in Munich, Germany in June.
Yeah, that's nice. We'll meet him there. Thank you.
Yeah. Thank you so much,
everybody.
everyone.
Thank you so much.
Thank you.
Thank you, everyone.
Thank you.
It was very
Thank you.
nice.
Thank you, Naveen. Bye.
Thank you.